Good morning, good afternoon, and thank you for joining us for today's VIA VitaFlow in association with you webinar. My name is Michelle Harrington. I am a registered dietitian on the Medical and Scientific Affairs team with VitaFlow North America. We are excited to bring you this educational activity and introduce our speaker. Today's topic is tackling nutrition in female teens with inherited metabolic diseases of protein metabolism, part two. Support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note, questions will be addressed during and after the presentation. Please submit questions into the Q&A pane at any time during the program. You will be able to access a PDF of the slides in the chat. 1.25 CPEUs are available for U.S. dietitians after listening to this program and completing the required knowledge assessment at the end. I will turn that on at the last 5 minutes of the webinar. So you will see it on the screen and then you could answer the questions in the knowledge assessment. If you don't see it or if you have any problems, please don't worry. You're going to get an email. You'll have my email address and just let me know and I can get that to you. Now, I have the pleasure of introducing today's speaker. Liz Tulin is a senior metabolic dietitian at Washington University in St. Louis, Missouri. Prior to entering metabolics in 2010, she was a pediatric dietitian in Norfolk, Virginia, working in oncology and critical care. In her current practice, Liz follows patients with inborn errors of metabolism from birth through adulthood. In addition to diet management, Liz educates training fellows, genetic counselors, and dietitians. Liz is an active member of the Genetics Advisory Board for the state of Missouri, serving as a dietitian representative for newborn screening and the state of Missouri Metabolic Formula Program. With that, I'd like to turn it over to Liz.
Thank you. Thanks, Michelle. Thank you, everybody, for being here today. As Michelle said, I am a clinical dietitian at WashU in St. Louis. If you attended part one, you see I have no financial disclosures. That we are continuing on our discussion about teens and teens with IEMs. And specifically today, we're going to talk about some cases. We're going to review the risks of elevated maternal Phe levels during pregnancy, some nutrition challenges. We're going to talk about some strategies and really try to understand some nutrition management principles for pregnancy, uniquely situated with teens who are pregnancy. So I've chosen a couple cases from our practice here. This, I will say here at WashU, I cannot take credit for all of these cases. These are from our history, and I work with a great group of dietitians who also worked on these cases with me, along with our fabulous team of faculty and nurses and nurse practitioners. So case one is going to be Sophia. So let's go ahead and do a little bit of background on PKU. I'm assuming everybody who is on here today has some foundational knowledge in PKU, but just in case, we're going to start from the beginning. So we know PKU results from the deficiency of the phenylalanine hydroxylase enzyme, PAH enzyme, due to variants in the PAH gene. And when you have these variants and the enzyme doesn't work properly, we result with a high serum phenylalanine or Phe level, low serum tyrosine. And the principle of management is a Phe-restricted diet with metabolic formula. Now, we know there's other therapies, there's other treatments, there's other options along the way, but for our conversation today, we're going to talk about just sort of our traditional management. We also know that untreated PKU has an abnormal phenotype. We see growth failure, seizures, we see global developmental delay, and severe intellectual impairment, again, with untreated PKU. So let's approach our case of Sophia. So we have a 17-year-old with PKU. We have, she had genetic testing confirmed in the PKU and the PH gene. She has two variants consistent with classic. She trialed sapropterin in the past with no response. She struggled in early adolescence with diet management. Her Phe levels have varied from 16.5 to 20 milligrams per deciliter throughout her teen years, not something that is uncommon that we see in our practice. Again, we talked about this in part one. The greatest factor in worsening adherence is age, right? So as people age with PKU, their adherence tends to worsen. And because of this, she started Pegvaliase 6 months ago with no demonstrated response yet. But she is on Pegvaliase and she has a Phe level currently as part of her management or her treatment with that. We're monitoring. Her most recent Phe level was 1208 or 20 milligrams per deciliter. She is eating a regular diet. She said she's not taking any formula. She is taking her meds. Of note, she also is on an SSRI, for anxiety and depression. So she's obviously struggling, right? So her Phe level is extremely elevated. Her level is 1208 or 20, and we want her to be closer to less than 360, right? She's having some side effects of the high Phe level. She's having some anxiety. She's having some depression. She's not taking any formula. And what do we get from her but a message in the patient portal? Hi, I really need to see you guys. I'm pregnant. Where do we go from here? So of note, she did not call us. She messaged us in the patient portal. This is a very teen thing to do. And she says, what now? So what are we worried about? So let's talk about maternal PKU for a minute. So when we talk about maternal PKU, this is really the only condition that we work with where we are concerned about the fact that the mom has PKU and it affecting the fetus. So not mom's health, but we're really looking at the fetus. So the first case reports came in 1957 where women with PKU were having babies who had severe intellectual disability, and they did a full-scale study in 1980, Dr. Levy. I think they did, I want to say it was like 415 births that they looked at, and they found some really interesting rates, significant rates. So for example, there was a higher incidence of spontaneous abortion, 24% compared to 20% in the normal population. Intellectual disability was 92% compared to 5% of the normal population. Microcephaly was 73%. So at that point, they actually said in this study, they determined that if a level was greater than 600 and they were farther than 12 weeks of gestational age, they had some extra additional counseling regarding termination of pregnancy. And the reason for this is why are we worried about this? Well, we know that high levels of maternal serum Phe or phenylalanine have teratogenic effects on the fetus. Teratogenic just means it's able to cause birth defects. And this is because Phe is an essential amino acid. It's shuttled actively from the mom to the fetus through the placenta in a concentrated amount. Nutrients are concentrated in the placenta for purpose of the baby, including essential amino acids, including phenylalanine. So fetal blood Phe concentrations could be twice as high as their moms. I've seen some reports as 4 times as much as the serum level of the mom is what is happening in the developing fetus. So that's why we have concerns about this. So based on these early research in the 80s, there's actually a distinct syndrome described now called maternal PKU. And what we see in these cases where the mom has high Phe levels, we see facial dysmorphism, microcephaly, so small head size, developmental delay, learning difficulties, congenital heart disease, and a low birth weight, so less than 2,500 grams. There was a landmark, the maternal phenylketonuria collaborative study, the MPK-UCS, They were the first, this based on this study was the first real evidence we had that said, actually, we can have great fetal outcomes if the blood Phe levels are actually controlled between 120 and 360. So they showed that a reduction in Phe before pregnancy or even shortly after conception has a significant impact on fetal outcome. They showed there were improvements in brain growth, neurologic outcomes, neuropsych outcomes, and that in these cases, congenital heart disease was virtually non-existent, which was great. So then our most recent guidelines are through the American College of Medical Genetics. So the ACMG put out guidelines saying, this is, we've learned a lot over the years. And actually, when I first started, some centers were recommending a Phe level of 100 up to 240. And so now we see that the ACMG recommends we want Phe concentrations between 120 and 360, or 2 to 6 milligrams per deciliter. Ideally preconception, but at least immediately after conception. We also have standards now for these women to receive continuous nutritional guidance, weekly or biweekly measurements of Phe concentration to make sure that those levels are right where they need to be, and then really continual assessment by the dietitian team to make sure there's adequate energy intake, proper proportions of fat, protein, and carb. And then also they have a recommendation for specialty testing, high resolution ultrasound, fetal echocardiogram during their pregnancy. So again, this is through ACMG too. What is happening when the fetus is exposed to these high maternal serum Phe levels? So we can see intellectual disability. This has been reported in over 90% of cases when the Phe level is consistently above 360 during pregnancy. We see poor behavioral outcomes, microcephaly, and the risk of microcephaly, which in turn tells us a small head size at birth really does not bode well for it really is consistent with intellectual disability as the patient grows. So when you have microcephaly, it's something we really want to avoid. The risk of this is 5% to 18% in pregnancies when the maternal Phe level is optimized prior to 10 weeks. If you don't optimize this Phe level by 30 weeks, your risk of microcephaly is now 67%. So it's definitely correlated with that. Congenital heart defects and other malformations. So due to the early formation of the heart in early gestation age, that they're consistently elevated maternal Phe levels, so over 600 in that early gestation can have a 8 to 12% risk of cardiac malformations. There are other dysmorphic features and other birth defects that have been reported in maternal PKU, for example, a TE fistula. And IUGR, this is very interesting. When the Phe level is well controlled, the risk of IUGR is no greater than that of the general population if it's controlled by the first 10 weeks. If the Phe level is not, then the risk of IUGR increases significantly if the Phe level is not optimized later in pregnancy. So let's go back to Sophia. We're all freaking out because she has a Phe level of 20. She tells us she's pregnant. She followed exactly what we told her. She called us right away or messaged us right away. And then she came into clinic right away. And we said, we got to get you under control. So we immediately restarted her PKU formula and her Phe restricted diet to 5 grams of protein from food. Here's her actual, I clipped this from her chart of what was prescribed to her. And I would like to point out, this was a challenge because reminder that Sophia had not been in good control for many years at this point. So as a dietitian team, we really went back to the last time that she had good Phe control. It was probably when she was 12. So her nutrition needs are different now as a 17-year-old pregnant woman versus a pregnant teenager compared to a 12-year-old. But we had to start from somewhere. So this is what we started. We restarted. She was on a fat-free adult PKU formula that was amino acid based. We picked her most recent goal. Remember, she's not counting, she's not tracking, she's on a regular diet. So we kind of plucked that through thin air. And the last time that she had been counting or tracking her diet, she's counting milligrams of Phe. And it's pretty much the standard in our clinic now that we're counting grams of protein when you have PKU. We're utilizing the simplified diet. So we had to do a lot of education on counting grams of protein because she had not done that before either. We scheduled her for an appointment with our nurse practitioner for the following week. Her fiance was coming, and we referred her to maternal fetal medicine, just like ACMG recommends. So one thing to point out here is that also not ideal is the use of a fat-free formula for a person who is pregnant in general. Fat needs are critical when you're pregnant, not only for energy, but also for sufficient fat precursors for brain development, for fetal brain development. So this was not our first choice. But again, meeting the patient where they're at, this is what she wanted to take. This is what the urgent need was to get that Phe level controlled. Okay. So in general, let's look at challenges associated in pregnancy with teens. So these pregnancies are often unplanned. 17-year-olds are not typically planning their pregnancy. And in this case in particular, is met with poor metabolic control. There's limited understanding of the risks. A lot of teenagers tend to do yeah, but not me. I'm not the one that's going to have this happen. And so even though you can explain all of these risks, you can explain all of the potential outcomes of a poorly controlled pregnancy from a PKU standpoint, there's still could potentially be a limited understanding of risks in these teenagers. Also psychosocial stressors and limited support. In Sophia's case, she was living at home with her parents. So she did have some support, but it was limited, as we'll talk about as we go on. So Sophia meets with our nurse practitioner, and she's really having a hard time. She cannot take the formula. She cannot stand the taste of it. She's struggling with nausea and morning sickness. Initially, she was able to improve her Phe level dramatically. She brought her level down to 346 micromoles. I mean, she was motivated and brought that level down right away. Then it jumped up to 705 because she couldn't keep anything down. She sent to us on my chart. She just doesn't know what to do. She said, it's so hard and my body and my head is literally blocking me from doing it. So we tried to adjust her formula where we actually, because she was not eating very much either, added a modular to her formula, hopefully changing the flavor a little bit to give her some more calories and some more protein equivalents. So on paper here, her total intake looks really good, well within the guidelines we'll go over in a minute, but she was really, really struggling to meet that. So as she continued to struggle with the nausea, she actually was admitted to the hospital initially for IV fluids and nausea management. The one thing that we did learn the hard way from this is at our institution, even though she's 17, when you are pregnant, you are an adult and you cannot be admitted to the children's hospital when you're pregnant. So we wanted to just admit her for some fluids, do some education, do some teaching, and she was admitted to the adult hospital, which is fine from our standpoint. We can go over there and see her, but the team is not the same as far as being, I guess, empathetic to kids the way that our patients are really used to. And the advice was just keep drinking your formula 3 times a day. That's what happened. Her levels did not improve, so the team decided to put in an NG tube, and that went horribly. The initial NG tube that they put in was actually one of the wide bore thick plastic ones for suction, not a feeding tube. And she got an awful nosebleed. finally were able to place an NG tube. She was able to get some formula in, and we trialed several different formulas with her in the hospital. We went through the gambit, and she just couldn't take any of them. We did improve her level a little bit during the hospitalization, probably from the extra calories from the IV and probably from the NG feeds, but she was discharged home without a feeding tube, without the NG tube, and she then came back to the ED for fluids and vomiting another time. And the first 10 weeks for her, her average Phe level ended up being 708. So not within our guidelines. We really wanted her to be less than 600, but there were a lot of reasons. So I just included some of her MyChart messages here to us. She really, you can tell her motivation is waning at this point, that she's sort of like avoiding us a little bit. I can't talk today. I'll talk tomorrow. I can't concentrate the formula. It'll be too powdery. I will get the levels down. I'm just really stressed. A lot of that. So you can see kind of a change in her tone here with us. So just some general tips for managing nausea and vomiting with this patient. When they admitted her, they gave her this doxylamine, pyridoxine, so this B6. This is kind of the standard, I think, right now for medication management. I encourage all of our pregnant patients to reach out to their OBs and really have them maximize this for them so that they can get adhere in the best way to their treatment. They can also use over-the-counter anti-nausea items such as ginger chews or candies, and just consider when it comes to food and formula, the odor of the liquids. Eating and drinking everything as much as possible through a closed cup, limited odor, cold foods to avoid the strong smell, breaking up the food and medical food into small, frequent servings also seems to be pretty helpful. So when we're looking at nutrition management guidelines during pregnancy, I suggest everybody to head over here. I cut this little clip here from the CERN SERN GMDI PKU toolkit. They can walk you through step by step in that toolkit if you've never taken care of a pregnant PKU patient, to give you really great guidelines there. So again, we want a Phe-restricted diet. There's increased calorie and protein needs, as we talked about in part 1 during pregnancy. And now we have more frequent Phe monitoring. So one thing to remember here too is that the diet for pregnant PKU women is more strict than the non-PKU pregnant women, right? So we're cutting down their natural protein initially to really achieve optimal Phe control. We might be giving them more formula. So we're giving them this more medical diet. You know, we're giving them more medical based, less foods. And so and then pair that with increased nutritional demands during pregnancy, they are at high risk for developing isolated nutrient deficiencies. So the monitoring changes during pregnancy. We're going to be looking at full amino acid panels. We do that once a trimester, more as needed, but at least once a trimester, we're going to look for anemias. So we're checking B12 and folate. And then also, if it's warranted, looking for essential fatty acid deficiency is also recommended. So specifically, these are the nutrients that we've talked about in part 1, and here again in part 2. Folate requirements increase from 400 to 600. Iron requirements, this is during pregnancy, from pre-pregnancy to during pregnancy. I took the pre-pregnancy I was looking at 14 to 18-year-olds. And then this is during pregnancy from the DRI. Your tyrosine needs increase as well. And DHA recommendations are a little bit variable, but from what I could tell is any woman who is childbearing age, they want you to get 350 milligrams a day. And then when you become pregnant, 100 to 200 more milligrams per day on top of that. And that reference is at the end. That's from the ACOG, I think the OB group. And when you are looking at your pregnant PKU patient, or really any IEM where you have a protein restriction and you're giving a lot of formula to meet metabolic demand, do not assume that your formulas meet these. The nutrient contents of the medical foods vary widely. And if you're being flexible to the patient and particularly allowing them, like we did, and a less complete, like incomplete with macronutrients. So she was on a fat-free formula, really for flexibility. That's something you really need to monitor and pay attention to, and not assume that they'll just make that up in diet, or that the prenatal will help them meet all of these needs. So definitely be plugging everybody into Metabolic Pro and looking, or whatever analyzer you use, that's what I use. So you are looking and making sure that they're meeting all of these needs in particular. And then revisiting this slide, we have these teens with IMDs. These are in addition to being pregnant, having an IMD, you're also a teen. So the need to be fit in and accepted, anger, there's guilt from not adhering. This is particularly high in maternal PKU when your levels are not controlled. There's some shame. There is some maybe low self-esteem and confidence from surrounding a teen pregnancy, concerns about long-term impacts, and PKU-associated mental health and neurocognitive issues from living with a high Phe level. There are mental health issues associated with that, potentially some disordered eating habits, and overall they have a higher risk, or more risk for a high-risk pregnancy, just by being teenagers. So we have a lot of, things confounding on top of our case here with Sophia. So common barriers to optimal control in teen pregnancy, again, social stigma, lack of knowledge or denial. This was something that I was not really understanding in Sophia's case. She's intelligent. She's getting straight A's. She is historically was well controlled as a child and does not have intellectual disability. And here now she's a teenager, and it's not really making sense why she's having such denial about her lack of control of her Phe level. And actually, there's a great study that I have in our references out of Germany, where what they did was they took, they sent a survey across 12 centers in Germany to anybody that had been pregnant, asking them a bunch of questions about their interpretation of their pregnancy. And they got all the surveys back, and then they divided it into a group of people who had great control during their pregnancy and suboptimal control. And they compared those results because they had their pregnancy data as well. So the ideal pregnancy group, so people who were well within their ideal range, that's what they called the ideal group, they had a realistic estimation of how they did during the pregnancy. And the subgroup they called suboptimal actually overestimated their own metabolic control. And they guessed that their own metabolic control was far better than what the data showed to be in 53% of the pregnancies. So what they found, they're actually in their discussion, they said their most important finding is that a substantial portion of pregnant PKU patients had an inaccurate self-estimation of their own metabolic situation. So this ends up leading to an overestimation of their control, and they maybe it's not really denial, but it's really just sort of a lack of awareness of how suboptimal their control was. And so they were surprised by signs of maternal PKU syndrome in their offspring. So they really said our current system of how we're doing it, patient education, even in a specialized center, is really insufficient because we're not really able to recognize that fully. So that was something for further study. And I found that to be really fascinating. In addition, we can also have situations with food insecurity or an unstable home environment, and mental health issues and resistance to care. So back to Sophia's case, her second trimester, she is not really gaining weight. Her fetal echo was normal, and she continued to refuse to drink her formula. She canceled a visit because she had COVID. That was pretty reasonable. So we did it with her on telehealth, and she said she broke up with her fiance. So her support system is getting worse. And when she did her labs, shows she also is consistent with anemia. She had some iron deficiency anemia. And in her second trimester, her average Phe level was 960. So even worse than her first trimester. We go on to her third trimester, and she's still seeing maternal fetal medicine. They schedule her for a C-section because of IUGR. So her estimated fetal weight is at the 8th percentile. She still continues to struggle with her formula intake. And this trimester, her average Phe was 920 or 15.2, so about the same as her second trimester. And overall, her average Phe level was 865. So I cut this from her actual dietitian note because it was really telling and actually kind of sad to me. It said that she seemed less motivated today than she was at her previous visit. She does not plan to make any changes to her formula intake, her diet tracking, and she said it is what it is. The damage is done. And she was sort of resigned herself to the fact that she did the best she could. She recognizes it wasn't what was wanted, and sort of she was moving forward from there. So what did we learn during this case, and why did I really pick this today? First and foremost, I wanted everybody to see that despite the fact that I think we're at a center where we're really good at treating people with PKU and helping them manage their diet, there's still challenges. And despite having a team that is really motivated and a team that really wants to help and a team that's engaged, there are still cases that are hard. And in this case, we had a full team that was on her side and really working, and still didn't have the outcome that really any of us wanted. There were some barriers I didn't talk about specifically, but in her second trimester, she had no insurance coverage for formula. That didn't really matter. I mean, she still wasn't drinking it, so that didn't make a huge difference, but it was something that our team worked on a lot to try to get her insurance coverage. And but she still was just insistent that that was the formula that she wanted. I say more formula alternatives would have been helpful for her to, meaning like, you know, for her to be open-minded to, but that was just a mental block that she just absolutely was not going to change. Calories, I can't really comment on what her caloric intake was because she wasn't diet tracking. So it was really challenging for us to know if she was meeting her needs at all, because we had no idea of what she was really eating. She obviously was not completely off diet because her level was better than when she was completely off diet. So she was doing something, but it wasn't hard for us it was very hard for us to kind of quantify what was happening. I do think that knowing she had a history of anxiety and depression prior to the pregnancy, she had this mental block regarding formula, it would have been really great to have a psychologist. We don't have that at our place, and actually getting her connected urgently with a therapist was not easy to do. We tried. There's just nobody that knows in our area that we could just like call quickly and say, help this person. So that would have been really great to have. And the stability of her support system, I think we all thought was much more stable at the time than in reality. So there was a lot of fighting. There was a lot of home stress that we weren't aware of, because every time they came to clinic, it was presented as, everything's kind of perfect. We're doing things great. And so there was a block there of that communication. The patient communicated pretty much exclusively through my chart. She did not like talking on the phone. She came to her visits, for the most part. But what would happen is she would message us on my chart. Her mom would call us. And that made it really difficult because remember, she's a minor. We had, permission to talk to her mom, but it would be different stories. So her mom would sort of be calling us for support, similar to all parents that have kids with PKU. My kid's not doing this. What do I do? My kid's not doing this. But it was different because now we have this patient, and we struggled a lot with confidentiality and where that line is in pregnancy for these patients. So her pregnancy outcome, little Miss Nora. She was born with IUGR and microcephaly. Her birth weight had a z-score of minus almost 2, with her length of -1, and her head circumference had a z-score of -2 on the Fenton chart and a -4 on the WHO chart. So pretty significant. And her developmental concerns started to be noted at about 5 months of age with her head control. She had normal cardiac evaluation. At about 1 year of age, she was not taking any solids. She was only drinking formula. Her growth was great. And she was not talking. At 15 months, she started having seizures. And this was really difficult for them. At 2 years of age, she had a G tube placed because of aspiration. She's now 3 years old, and because of her seizure disorder, she's been started on a keto diet. She walks independently and she babbles. She doesn't have any words yet, but her family is managing a complex situation really well. Sophia, post-pregnancy, restarted pegvaliase in 2023. She said she's very stressed and overwhelmed taking care of a medically complex child as a single teen mom. And so she really wanted to get her Phe levels under control. She enrolled in college courses. She has responded to pegvaliase well. Her level has dropped. With her level dropping, she has had improved adherence with her formula. She takes her formula now without any problems. She tracks her diet. Every time she submits a Phe level, she has diet records, and her motivation to take care of herself is in a very different spot than it was when she was pregnant. So just some additional considerations during pregnancy. So when we're looking at PKU formulas, initially, I always look for higher calorie formulas if possible, especially if they're on a low cal formula to start with. We add modulars like crazy to enhance calories. You can use the just carb, or you can do carb and fat. Consider a GMP product, even if it's just one serving a day, for the benefits of satiety, for absorption. I think it's better tolerated from a taste standpoint, and nausea from a morning sickness standpoint, and consider lower volumes if the calories allow. Sometimes you can't get low volume if you're trying to get in a ton of calories. Also, some considerations would be sapropterin. The ACMG guidelines say it's safe for use during pregnancy. They say everybody should use it if they respond to it. And then pegvaliase, the data is not there yet for them to give a full recommendation. It's not conclusive, but they don't say stop it. And anecdotally, there have been case reports, if you look, there are many healthy pregnancies on pegvaliase. And it's a question we ask ourselves as a team: should we have kept her on pegvaliase? Remember, she wasn't responding yet at the time, but should we have kept her on it? Hindsight is always 2020. We don't know, especially knowing now how well she's responded to it, perhaps. But she, did have a couple reactions along the way that you might not have wanted to have when you're pregnant. Those are just some things to think about. And so some communication tips for teens: visual aids, mobile apps. They want to type their feelings to you, at least what I've experienced. They want some empathetic and non-judgmental counseling, setting small, realistic goals, and engaging caregiver support when possible. Okay, so that's our maternal PKU case. Before we dive into our next case, I pulled up another one that I thought was really interesting. And this is a tyrosinemia type 1 patient that we followed for a teen pregnancy. So we're calling her Bella. And Bella is a 16-year-old with tyrosinemia type 1. And she presented to the office when she was 13 weeks and normal, healthy weight. And she was on nitisinone, vitamin D, prenatal vitamin. She was historically struggling with diet and formula adherence. as many of our teens do. And I would like to preface this that this is an old case. I have limited data. So what I have here is what I have here, is what I could pull from the chart. And and there was limited information about what else was available. So we're just going to go with what we got here. So let's talk about tyrosinemia. You may or may not taken care of anybody with tyrosinemia in your clinic, but we have over the years we've had a handful, and tyrosinemia type 1 is what we're talking about specifically, and that is caused by deficiency of the enzyme FAH. And the diagnosis of tyrosinemia type 1 is established by having a moderately elevated tyrosine and the presence of succinylacetone in the blood or urine. Now it's diagnosed on newborn screening. Back when Bella was born, it was not yet added to newborn screening. So she was actually diagnosed when she was a toddler, and through sort of a diagnostic odyssey, but now our patients are mostly diagnosed on newborn screening. Management for tyrosinemia type 1 is use of nitisinone or NTBC. This is a medication that blocks the accumulation of succinylacetone. So in comparison to PKU, where we're talking about Phe levels are teratogenic, can be teratogenic to the fetus. The high Phe levels cause the neurotoxicity in our patients. Tyrosine is not the really bad offender here. Succinylacetone is the really bad offender. So succinylacetone is what causes liver failure, neurologic crisis, liver cancer. So that's what we want to go away. When we use the NTBC to get that to go away, it prevents the accumulation of that. But consequently, by using the NTBC, it prevents the accumulation of succinylacetone by completely blocking the tyrosine degradation pathway, causing the tyrosine levels to be elevated in patients. And when you have a high tyrosine level, it can cause different side effects. It doesn't cause brain damage. It actually the tyrosine can accumulate as crystals in the eyes. It can cause porphyria, which is accumulation of crystals in different parts of the body, and the abdomen can be really painful. So when you're using nitisinone, we recommend use of that in combination with a tyrosine restricted diet. So the diet is similar to what we're talking about with PKU: low natural protein, restricting the tyrosine, and then use of the tyrosine metabolic formula to meet all of the protein demands for the patient. In this case, maternal use of NTBC was not well studied at all. In fact, Bella was one of the first patients in the US. I think she was started on an early access before it was even FDA approved for use in tyrosinemia. So she had been on it for 15 years at this point with great success, but there was not information about what would happen to the baby. What we do know is that if they stopped the NTBC, she would have, so Bella would have risk of acute liver failure, neurologic crises, and liver cancer. So the team decided to keep her on the nitisinone during her pregnancy and really encouraged her to restart her diet. So after her first visit, she restarted her formula right away. She came in and she was on a ready-to-drink amino acid-based tyrosine formula, a little pouch with a screw top lid that you could reseal. She was supposed to take 3 of those a day, and she said, can't do it. So she came to her visit, wanted to explore other options, and there were not many. The only other options at this time was the formula she had taken as an infant, that kind of formula. And then there was a powdered formula in a pre-measured sachet that was 15 grams of protein in a package. So they trialed that, and she actually mixed it into dairy-free ice cream, just dumped it in there, stirred it around, and ate it 3 times a day. And she did really well with that. She limited her diet to 20 grams of intact protein a day. So her total was 65 grams of total protein. Note that this was a little bit below the guidelines of total protein for pregnant teens in general. She should be up to around 70. So we've had a second trimester visit with her. Overall, improved adherence during pregnancy. She was taking her formula. She's keeping daily food logs. She's bringing them into the dietitian. The dietitian does a wasn't me. Dietitian does a diet analysis and notes that her diet is really not complete. She is being a teen. She's eating a lot of prepackaged, a lot of carb-heavy foods, not very many fruits and vegetables, not a lot of fiber. So they did they checked some additional labs at this time. They screened for anemia, and those were all normal. Her tyrosine level was 475. Our goal here is less than 500, so she's doing really well. And also noted that she is B12 deficient. So started on weekly B12 injections. So again, double checking your formula, even though she's taking her formula as directed, that might not be supplying enough B12. We can tell she wasn't eating animal products. She was at a risk for B12. And so they corrected it. So then her third trimester, she starts to struggle a little bit. She's got some nausea. She stopped tracking her diet. She's actually eating some high protein foods like cheeseburgers. And she comes to clinic and she says her eyes hurt. And we're not surprised because she has a high tyrosine level. And so, the dietitian really met with her, listened to her, and said, I know this is hard, but you can do this. Let's look at what our other options are. So she decides to go back to her ready to drink formula, the one she was on initially. And the dietitian says, take it like a medicine. You're so good at taking your medicine. And actually, she suggested taking it 1 ounce, 30 mLs, 10 times a day. That was too much. So they settled on 60 mLs 5 times a day and increased her intact protein goal as well. So she's now able to eat a little bit more, and she was able to do it. So her outcome is that she delivered a healthy baby girl. Birth weight was normal. Her tyrosine was elevated on newborn screen, but there was no succinylacetone. So tyrosine is elevated because Bella's tyrosine was elevated. And a month later, at a month of age, her repeat serum amino acids were normal. Bella continues to take the ready to drink tyrosine formula because it makes her feel better, especially her eyes. And at that visit, the physician noted that she did have some postpartum depression symptoms, and she was referred for local evaluation and started on some medication. And at this visit, her plasma tyrosine was 658. So what did we learn from her? So we used a novel therapy for her. At this time, there was really little guidance. The team met with Bella, her mom, and they went through the risks, and they decided that that was the best way to proceed. And I think the team did a really good job listening to her and being open to alternatives, offering a flexible formula schedule. Now, we have GMP options for tyrosinemia patients. I think the patient, actually, I follow her now, and she takes a GMP product with excellent adherence. She still does mixing. She's dumping it into shakes and all kinds of stuff all the time. She's still really creative with it, but she really prefers that product over what she was taking back in her first pregnancy. She has since had more pregnancies. And if you're curious about how her case turned out, my slide's not advancing. There you go. They actually published this report in the Journal of Pediatric Gastroenterology. My predecessor, Lori Spritzma, who taught me everything, they published this in 2015. And this is also my plea. If you have any interesting cases and you think, who's going to want to read about that? Write it up, because we are all interested. This is how we all learn about cases. So definitely write them up and get them published. Here's my references. Those are all available for you on the PDF. And I just want to say thank you to VitaFlow. Thanks to my team. And my email is up here. So if you have any questions, feel free to email me after this if you have things that you want to chat about.
Oh, thank you, Liz. This was such a great
Thanks, Michelle.
presentation. I love that you presented a patient who didn't have the best outcome, and that was a challenge from the beginning until the end. I just think there are so many learnings there. I also second Liz's plea. We love case studies. I hope the audience will complete the survey at the end of this.
Yeah.
One of the questions is, what else would you like to hear about? And sometimes people are like, more cases. We could do another whole webinar just on various cases. So we're dying to hear what you'd like to learn about. I do have the knowledge assessment running right now. So hopefully you can see it, you can answer it. This is a requirement from CDR just for the US dietitians to get your certificate. And I will email that to you tomorrow. I can see who answered. At this time, I just want to see if anyone has any questions. There are no questions at the
Oh,
moment in the queue here. There's nothing in the chat, but I do want to give it a minute. While we're waiting, I do have a question for you, Liz, and it
that
has to
sounds
do
great.
with Sophia.
Yes.
So I thought it was interesting that you used a fat-free formula, and I know this was patient-driven. I also know you acknowledge the importance of fat in the diet, but I'm wondering, would you ever do that just as a tip or a strategy to help with nausea?
Yeah, I mean, it can. I think that's why she preferred that formula, to be honest, because it is lighter, than than some of these others. But um, if in a case where I was thinking about her case and saying, wow, we really didn't do a good job addressing her fat needs. But the reality was she wasn't taking her formula and she was really eating a varied diet and gaining weight and all of that stuff. So we didn't really have to focus on that. But if she had adhered to her formula strictly and her diet strictly, we could have put her at some risk for essential fatty acid deficiency, by not supplementing that properly. So it's just something to really pay attention to. And it seems like weird to order a panel, essential fatty acid panel on a patient with PKU, but in those cases, it could be really critical.
Yeah.
Yeah.
Okay. We have a lot of questions now, so let me
Oh,
hit you.
okay.
This is from Sarah.
Okay.
Why did your first case not go home with the NG? Sorry if I missed it.
Yeah, no, that was a good question. She really refused. And we ran
Okay.
into a lot of roadblocks where, we know adults get to refuse a lot of things that kids don't. So we had our hands tied in a lot of ways where, in that she was at the adult hospital, maternal fetal medicine was taking care of her. And they do things a lot differently where they have a lot more autonomy and get to just sort of do things that they want to do, even if it's risking the baby. So we had a hard time with that. We wanted her to go home with the tube. That was the whole plan, to have her admitted, get the tube. And honestly, I would have just had her keep it her whole pregnancy. That to me would have been really easy, but she was adamantly opposed, the patient, and that team was okay with it.
Okay, this is also from Sarah. It's not a question, but a comment. Thank you so much for this, Liz. It's so validating. I have also had some really challenging pregnancies. Wonderful presentation. Thank you for that, Sarah.
Thanks,
This is
Sarah.
from Natalie. Why do you think the adherence was harder after the pregnancy than during the pregnancy?
Oh, that's great. I mean, in general, this is not teen specific or these case specifics, but in general, your protein limit increases throughout. By that third trimester, a lot of women are eating more protein than they maybe have previously, pre-pregnancy, because of the growth of the fetus, because of anabolism in general. So a lot of times it's hard to go from that back to what you were doing before. In these cases, I think that for both of them, and a lot of it is being a new mom. So I think some of the planning, the organizing, all of that is much harder when you have a baby at home. These were both 16, 17-year-old girls who were faced with the challenges of being a brand new mom. So I do think adherence is really hard in general in those cases.
Okay, this is from Brooke. I'm curious about your thoughts on admitting pregnant PKU patients with elevated levels. Did you ever consider readmitting her after the first admission?
Yeah, I mean, A lot of places will do that. I actually read in one of the articles. It's kind of older, but they were admitting everybody for 3 to 5 days every pregnancy. For as soon as they found out they were pregnant, they're admitted for education, for teaching, and to get their levels under control. And I think that's a really idealistic way to look at it. I don't know a lot of insurance companies that might cover that, or people that could take the time, but that would be an ideal situation. I think that our team tried really hard, but because the initial admission wasn't as successful as we wanted it to be, we couldn't really justify readmitting her during the pregnancy.
Okay, this is from Rachel. I apologize if I missed this, but was Sophia on Palynziq prior to pregnancy?
Yes.
Yes.
Mhm.
Do
Yes.
you do
Yep.
you keep patients with maternal PKU on Palynziq now?
So that's a really great question. So she was on Palynziq but had only been on for 6 months. Um, we've talked about it as a team now. Our general rule is if we have somebody on Pal who is responding and doing well, we would not stop it just because they're pregnant. In her case, we didn't really know. We didn't know if it was safe, it was not, but we knew that her level was 20. She was taking her off of it was not going to change her Phe level. But in retrospect, if we'd kept her on it, maybe she would have developed a response during her pregnancy. That could have been helpful. That's something we just didn't know. But you're right. Now I would not take anybody off Palynziq just because they're pregnant.
So, yeah, that's actually what Rachel said as part of her question. That's often what their clinic has been doing if levels have been high and likely to not be controlled.
Yep,
Yeah,
exactly. Yep, yep. We know what a high Phe level does to the baby. We know that. So
yeah.
we would think that would be riskier to take them off their treatment that's working, or you know, um, yeah.
Okay. Okay, this is from Zazzle. Not a question, but great presentation. It is very
Thanks,
important to
Hazel.
know that although the advances are occurring, it's still happening. Oh, thank you,
Thank,
Zazzle.
thank you.
Okay, this is from Sylvia. Great to hear. It'd be great for a multi-clinic publication on these cases. Love that, Sylvia. Love that a lot.
Yeah, agree, agree.
Okay, I don't see any other questions. I just again want to thank Liz for an awesome presentation. I want to remind you that this is part two. Liz had really nicely set the stage with just challenges with teens, with inborn errors of protein metabolism, and then she touched on pregnancy. And you can get this on our VitaFlow Via site. Listening to the recording, you can get the 1.25 CPEUs. And then if any of your colleagues missed today's webinar, this will be posted on our VIA site shortly. And the CPEUs for listening to the recording are pending, but you can get them for the live recording immediately. A lot of people were able to complete the knowledge assessment. I can see that. But again, if you didn't see it on your screen, just reach out to me when you get that email and I will get it to you. But again, I just hope this was helpful to your practice. And I really thank everyone for joining us. And thank you again, Liz.
Thank you. Thanks for having me.